I'm Anna Delaney with the Carolinas Poison Center, and this is an introduction to Flu on Call. Flu on Call is a project that was initiated by the Centers for Disease Control a few years ago. Multiple national groups, including the American Association of Poison Control Centers, are participating. Carolinas Poison Center is part of this project. One of the major goals of Flu on Call is to determine whether or not a network of phone lines, including United Way 211, medical insurer and VA nurse triage lines, and poison centers could work together to triage and assess questions and potential patients during a severe flu pandemic. Minor goals would be to try to keep people out of the emergency department and physicians' offices who did not need to be there to hopefully reduce spread of a highly infectious flu. The CDC and its partners have been working for a couple of years now on trying to determine what would need to be done in the event of a flu pandemic. Having drills to assess the functionality of all these different participants is necessary to determining how well something would work. So we are going to have a drill this fall in which we will have lots of people participating. But there have to be some assumptions every time you have a drill. So some of the assumptions include the fact that this is a severe pandemic going on, that medical facilities and clinics will be overloaded with patients and there will be delays in appropriate treatment, that antivirals, if they're available, will be still prescription only and patients will need to get prescriptions. There needs to be a nationwide availability of services so that if one area is hit very hard, they could call on another area of the country to participate and help triage patients over the phone. There's the idea that it would be great to keep some people at home, if at all possible, and that the participants could provide accurate information and recommendations based on a single central protocol, and that this could possibly be used for other public health emergencies. Other assumptions include the fact that the national network of triage lines would be working together probably, hopefully, several weeks before the Surgeon General declared a pandemic in the United States. And that this would happen when there are large proportions of people having influenza-like illness and the medical systems in multiple areas cannot keep up with the need for care. And doing this while maintaining patient safety, so providing good care and keeping people safe, but managing a large pandemic is really kind of what we're targeting here. So here's the ideal flow. There would be a nationwide toll-free number for anyone to call. They would be prompted to enter or state the state that they're calling from so that the call could be properly routed to the nearest 211 center. The 211 specialist would then determine whether or not the caller is ill with potential flu or is caring for someone with potentially influenza. If not, the 211 agent would provide prevention information, some practical information, and then possibly finding out, if necessary, where that person would seek care should they become ill. If there is a patient with possible influenza-like illness, then the 211 agent would determine whether or not the patient is a member of a participating plan that has their own nurse triage line, like one of the major medical insurers or the VA. If so, the patient or caller would then be transferred to that nurse triage line. If the patient does not have medical insurance, is not a VA patient, or their carrier does not provide a nurse triage line, that caller or patient would then be transferred to a poison center. In the event of a pandemic flu, the CDC would develop a master triage and treatment protocol, probably more than one for adults, one for children. Those protocols would then be shared with state and local health departments. The state and local health departments could adapt them based on what's going on in their region and what the level of care is in certain areas. And then those protocols that the state or local health department has adapted would be shared with their regional poison center, who would use their regional specific triage protocol. So there have already been 3 drills conducted. There were 2 in May of 2014. The first one was just with United Way 211 centers, and can they handle calls and questions about influenza or possible patients with influenza and properly transfer calls to a poison center or nurse triage line. The first drill that poison centers participated in determined whether or not we could handle a just-in-time protocol, meaning it was developed just in time for the event, to triage and assess patients who may or may not have influenza-like illness and make proper recommendations as to whether or not they need to go in for care, if they could take an antiviral and stay at home, or if they did not need any type of information other than prevention. And could poison centers handle a call surge while maintaining their normal function? And could they provide access to antiviral prescriptions? Could they determine who needs one, calculate the dose, and get a prescription to a participating pharmacy? The third drill combined 211 and poison centers to assess whether or not 211 centers could properly send cases to poison centers, and could those poison centers use an informational database to find which pharmacies had the antiviral prescription medications and calculate the appropriate dose. So the reason you have drills, as we all know, is because nothing works perfectly the first time you try it. So there were some lessons learned, and these are mostly from the CDC, but there's a few that we determined on our own were things that needed to be thought about for future work. There needs to be a warm transfer from the 211 specialist to the poison center, where the 211 specialist introduces themselves and states to the poison center who they're transferring and why. The CDC is asking everyone to answer the phone with a standard greeting, which is on the slide. One of the things that we learned is that before this starts, everybody really needs to have a good idea of what the protocol says and how you manage high-risk patients, how you determine who can go in for local care versus the emergency department, and when antivirals are needed. We also need to have a better idea of the side effects of the antiviral medications and to be able to teach and tell the patients or callers about them in a relatively quick manner. Again, we need to be able to listen well to make sure that we're determining whether or not this is flu or not, and that we needed to have better integration with the database that gave us the lists of pharmacies that would have antiviral medications. And then also we needed better information as to what sites are in the community to help patients who don't have primary care providers at this time. Some of the issues that were not addressed last year that we know would be a problem in the event of a true pandemic are some of the things like transportation. What if the patient doesn't have transportation to the pharmacy? What about uninsured patients? The antiviral medications are expensive, and would they be able to get them? Would they be able to get can they afford the over-the-counter pain relievers that sometimes we would recommend to help with symptoms? Can the patient really be cared for at home? Is there a competent caregiver? What about language barriers when we're handling these phone calls? Is there a translator line that can handle a call surge during a flu pandemic that we would be using? So all of these things are social issues that we know exist, but they really need to be addressed more this year since they weren't at all last year. So our next drill is on September 9th, and it is starting with some basic assumptions: that there's a pandemic flu outbreak, that emergency departments and care provider offices are overwhelmed, that we know the flu strain, and fortunately it's susceptible to available antiviral medications, and that those medications are in good supply and not currently in shortage. So this is how the drill is going to go on September 9th. There will be 2 1-hour, 45-minute live sessions, one in the morning and one after lunch. The CDC will utilize trained actors who will have scripts that they follow for each call. They will make all calls to one toll-free number that will be provided to them, and the 211 centers will get those initial calls. The United Way 211 agents will triage those calls and transfer patients or callers that they think need to be evaluated by the Poison Center to the Poison Center. We will use the guidelines we've been given for adult and pediatric patients to determine whether or not the patient has flu-like illness, if they need to go to the emergency department, if they need to be seen today by a provider, or if they can have an antiviral at home, or if they're beyond the point where antivirals will help and they just need some good reassurance and home care instructions. There will be a database that will be able to give us a list of pharmacies in the patient's zip code that would have antiviral medications. The database is also going to have a way to calculate the appropriate dose, say in a pediatric patient, of those antivirals. And then we will mock prescriptions to pharmacies for those patients that need antivirals. And then in between, there'll be kind of a hot wash, a discussion of how things are going. And at the end, of course, there's an evaluation of how well we did. But that's essentially how the day is going to go. We look forward to working with everybody and hope this goes well.